Good morning.
Yeah.
Welcome to Ground Rounds. It's a pleasure for me to introduce Dr. Anjali Malkani. She is a professor of pediatrics at East Tennessee University in Johnson City, Tennessee, and she undergo medical school in Calcutta University, part of the medical college, and her residency in pediatrics in St. Petersburg at All Children's Hospital. She's also completed her fellowship in Stanford University in California. She's written many chapter of books in pediatric GI, and she actually completed the last, she was involved in a grant, actually as soon as last year, studying the outcome of children post-cholecystectomy in a population of Northeast Tennessee. And she's presently the chief of pediatric gastroenterology, where she works at East Tennessee University, and it's a pleasure to have her here. Welcome, Dr. Malkani. Thank you.
I don't need that, right?
Oh, yeah.
Thank you. Good morning. It's great to be here bright and early. I have no disclosures to make, but I do want to say something. When I picked this topic, I started looking through the literature, and it was really disappointing to see that there really isn't a whole lot written on the management of children with pediatric upper GI bleeds. A lot of the literature is from the adult population. So we'll go through this. Learning objectives for today, I'm going to review certain terms that we use in kids with upper GI bleeding, review the etiology of GI bleeding, resuscitation, risk assessment, pre-endoscopy management, the role of endoscopy, post-endoscopy management, and outcomes. So definitions, mainly for the medical students and residents here, okay? So what is a definition of an upper GI bleed? It's any blood loss arising from the esophagus, stomach, or proximal duodenum, mainly above the ligament or trice. A mid-intestinal GI bleed is from the distal duodenum to the ileocecal valve, and a lower intestinal bleed is arising from the colon and the rectum. Looking at the color of the blood, we can sometimes tell the origin and the pace of bleeding. So what are the terms that we use? Hematemesis is vomiting of blood. Bright red usually indicates active bleeding from an upper GI tract. And if you see coffee grounds, it's dark blood, dark-colored fluid assumed to be blood. But word of caution, this hematemesis can be from swallowed nasal blood or from maternal blood in a breastfeeding infant. So melena is the dark, tarry, pungent stool. Once you've smelled it, you'll never forget the smell of blood in the stool. And it's usually suggestive of a GI origin, but if there is a small intestinal or proximal colon bleed with a slow pace of bleeding, it may show up as melena in the stool. So we need to be cognizant of both those facts, of the swallowed blood in hematemesis and a slow, mid to lower GI bleed with melena. So hematochezia is a term that we use when we see bright red blood per rectum. It's usually suggestive of a lower GI bleed, but there's always a but, right? But if there is a massive upper GI bleed and rapid transit, blood is a cathartic, and you can see hematochezia from a massive upper GI bleed, okay? So we often say guaiac positive stool. Guaiac positive just tells us that there's a cult blood in the stool. It does not provide any localizing information. It just means that there's blood in the stool. And it usually indicates a slow pace, usually low volume bleeding, that you haven't seen the hematemesis, the melena, or the hematochezia. So if you need a card to tell you whether there's blood or not in the stool, it's not an acute GI bleed. If the family didn't report any of those findings, it's not an acute GI bleed, okay? So I tried to look to see what's the incidence of upper GI bleeding in children. I found a couple of articles dating back to 2010 in European journal. In France, a population-based study reported an incidence of 1 to 2 per 10,000. Of those, 77% required hospitalization, and a third of them had NSAID exposure as a cause of their GI bleeding. In the US, I found an article based from a PICU setting, so these are already inpatients, and the incidence of GI bleeding in the inpatient PICU population was 6.4%, and the risk factors were if they had pneumonia, trauma, or coagulopathy. There was a recent, 2016 article from England, and the estimated incidence in the UK was 300 to 500 per year, but that didn't make any sense. So I Googled last night, what's the population of children in England, and it was 18 million, and if you do the math, it's like 0.05%. So when we're seeing a child with an acute upper GI bleeding, we first have to figure out, is this an upper GI bleed or a lower GI bleed? And what do we think is the most likely source? And once we figure that out, then we need to figure out how sick is this patient and what are we going to do with this patient? Where are we going to admit the kid? How are we going to resuscitate the child? And when and how are we going to do endoscopy? So how would these kids present? They could either present, like I said, with hematemesis, melena, or hematochezia, okay? Sometimes they may not report any of these symptoms, and they'll just say they're pale. The parent will notice that the child is suddenly pale, or the child all of a sudden is fatigued because he's bled internally and you just haven't seen the blood come out as yet. Or they may just one day just pass out on the way to the bathroom. We see that a lot. And then when you start getting history or while they're being evaluated, in the ER even, sometimes they'll just vomit or pass the melanotic stool. Okay? So what are the common causes of upper GI bleeding in children? It's good to think of it based on their age. In the neonate, that's from birth to 1 month old, most commonly we see swallowed maternal blood. And the medical students are always in awe when I say, on a breastfeeding baby, did you examine the mother's nipples? And they look at you saying, what? It's part of the exam. It's part of your history taking. So swallowed maternal blood, coagulopathy, either due to vitamin K deficiency, sepsis, or liver disease, stress gastritis or stress duodenal ulcer. Sometimes we'll see milk protein allergy or severe reflux esophagitis. And then we always need to think about any anatomical vascular malformations in a neonate that presents with hematemesis or melena. In an older child, the most common thing we see is Mallory Weiss tear or prolapse gastropathy from retching with vomiting. Often we'll see stress gastritis or duodenal ulcer, esophagitis from either peptic disease, infectious etiologies, or even a pill esophagitis, gastritis from H. pylori or chemical-induced from NSAIDs or alcohol, and somehow that age seems to be going down with that alcohol. Always need to think about an esophageal variceal or gastric variceal bleed, coagulopathy, vascular anomalies, Delafoy lesions, which are malformed arterioles, so it's an arterial bleed, and it has massive GI bleeding. And then rarely you can see an aortoenteric fistula in this day and age from magnets that get, or button batteries that get lodged in the esophagus and burrow through. Here are some pictures. This is a picture of a Mallory Weiss tear. Spend a little bit of time talking about esophagitis in children. Like I said, you can have peptic disease, acid reflux. Eosinophilic esophagitis typically doesn't present with GI bleeding, but it can cause esophagitis. Pills, notorious pills are the antibiotics that teenagers take for acne, and they swallow it at night before going to bed without any water, and then they lie flat, and then you get pill esophagitis. Foreign bodies and infections, HSV, CMV, Candida, and Aspergillus. You always associate these infections with immune deficiency, mainly the CMV, but HSV can be seen in immunocompetent children too. In fact, I just had a child, 14-year-old, that presented with severe odynophagia, and they had tried PPI and Carafate and scoped him, and he had HSV. He didn't have bleeding, but he had severe odynophagia. So this is a picture, didn't come out that good, of peptic esophagitis. As you can see, there's erosions in the distal esophagus. Here's the typical findings of herpes esophagitis, these ulcers in the esophagus. You can see that they have a raised margin, whitish raised margin. This is Candida, thick white plaques in the esophagus in kids post-kidney transplant patients on immune suppression. And here's pictures of duodenal ulcer. Right there, you can see that ugly-looking ulcer and a visible vessel down there, and there's a gastric ulcer from peptic disease. Here's acute gastritis from NSAID use. And this is the lumpy, bumpy look that we see in H. pylori in the stomach. So H. pylori gastritis, it's a typical lumpy, bumpy look with H. pylori gastritis. And there's a host of vascular anomalies that can cause bleeding, GI bleeding in children, varying from capillary disorders to venous, arteriovenous malformations, and then the one that causes the massive GI bleeding is the de la Foy lesion. You can see the blood spurting out from that arteriole. There's active arterial bleeding. Okay. This is a picture of esophageal varices in a child with portal hypertension. You can see these swollen vessels down the lumen of the esophagus. I'm going to spend a little time talking about, just to refresh your memory about how these varices form. If you remember, the portal vein is formed by the splenic vein and the superior mesenteric vein. And if there's any portal hypertension, the pressure is high up in here. They develop collaterals between the portal circulation and the systemic circulation. And they form collaterals up in the esophagus that forms the esophageal varices. You can even get gastric varices. And then there's anastomosis between the systemic and the portal circulation around the umbilicus. That's your caput medusae. And then you also can get internal hemorrhoids from portal hypertension. This is a picture of portal gastropathy. So the portal hypertension causing portal gastropathy that can bleed too. So, key is to get a good history. Always ask about the quality and quantity of blood. If there was any retching, that would make you think there's a Mallory Weiss tear or prolapse gastropathy. If there's pain, ask about the pattern. You could sometimes come up with a diagnosis of peptic disease based on the pattern of the pain. Past stooling habits. If there's any bleeding from other sites, that would make you think that there's an underlying coagulopathy. Ask about medications, non-steroidals. I learned my practice in East Tennessee. I was introduced to a powder that people take for aches and pains, which is loaded with aspirin. I had no idea what it was. I'm assuming it happens here too. Yes, I'm not supposed to say the name. I had no idea. I also did not know what dipping was till I got there. The mother told me, yeah, a 12-year-old, he dips. I'm like, what's that? Learned the hard way. Alcohol, smoking, okay. Ask about birth history, if they ever had a UAC or a UVC that puts them at risk for portal hypertension. And then family history, if there's any family history of liver disease, atopy, inflammatory bowel disease. Diet, another rude awakening was the diet in East Tennessee. People drink that yellow drink for breakfast that's loaded with caffeine. And there's also another drink that's made in East Tennessee that has caffeine in it. It's indigenous to that area. I did not know. And it's the first ingredient is caffeine. So ask about diet. And then past surgeries, they could have an anastomotic ulcer that bled. Okay. Things to look for in a physical exam. The most important thing is how stable is your patient. Look at the vital signs, hypertension, tachycardia. Often the ER will call, say the kid came with hematemesis with hypotension, tachycardia, and I'll ask the resident, hypertension, tachycardia, none? Oh, good. Did you do orthostatics? And sometimes when we get the orthostatics, that's a key that this kid, if there are changes in orthostatic vital signs, that this is a child you need to watch because they're going to go down the tubes quick. Okay? Look at pallor, capillary refill. Look for telltale signs of underlying liver disease, jaundice, rash, Stigmata of chronic liver disease, the erythema, and the don't often see that in kids, but we still look for it. The caput medusae, if there's portal hypertension. And then we also look in a kid that comes with any GI bleeding for any telltale signs of any vascular anomalies. Scan the skin really quick to see if you find any hemangiomas on the outside, on the skin. May signify something that you're going to find that bled in the gastric mucosa or upper GI mucosa. See if there's any abdominal tenderness. Rarely you may have a kid that has a perforation that presented with a upper GI bleed. Always feel for a liver and spleen. If you see a big spleen, you start thinking about portal hypertension. But always need to remember that if the kid is intravascularly depleted, you may not feel the tip of that spleen, okay? My pet peeve is always look at the child's bottom if you can. Look for tags. It tells you telltale signs that there could be underlying inflammatory bowel disease. If there's any hemorrhoids or a fissure, makes you think that there could be constipation or portal hypertension. Okay, you're all familiar with the PEWS score, right? To be cognizant of changes in vital signs and behavior that tells you that there's going to be impending doom. The child's going to have circulatory collapse, okay? So what is a workup that we need to consider when the child comes with an upper GI bleed? Obviously, we get a CBC, okay? And as a gastroenterologist, we still look at the white count to see if it's elevated. Maybe there's an infectious cause, and if it's low, always think about hypersplenism and portal hypertension. Then we look for thrombocytopenia, once again, to see if that could be the cause of the GI bleeding, or, once again, portal hypertension. And then when we look at the hemoglobin hematocrit, you look to see if it's low or not. Always key in and look at that MCV, because if the MCV is low, then it tells you that it could be an acute on chronic bleed. If it's an acute GI bleed, the MCV should not be low. If it's low, then you see that it could be acute on chronic bleed. Check coags, looking for coagulopathy, and also the synthetic function of the liver. We look at the CMP, looking at the liver functions, the albumin that could tell you that there's underlying liver disease. But a high BUN, and in adults they say a BUN creatinine ratio more than 20 signifies an upper GI bleed. And it tells you that the body has had time to allow reabsorption of the blood, the protein, and that's why the BUN goes up, okay? Consider an amylase lipase if there's pain. Always get a type and cross, always have to stay ahead. And you can consider a Doppler ultrasound if you're thinking portal hypertension, or a KUB if the clinical condition warrants looking for perforation. So I'm going to talk about the resuscitation and endoscopy that we do in kids with upper GI bleeding. So in resuscitation, I'll leave it to our esteemed colleagues in the ER and the ICU to take care of the intravascular volume and the blood loss. Talk about the indications and benefits of dropping a nasogastric tube, reduction of gastric acidity, correcting that coagulopathy, and then in the urgent situation to consider balloon tamponade if you think that there is a diagnosis of esophageal varices. Okay, so from the adult studies, we know that early intensive resuscitation reduces the mortality, the need for blood transfusions, and the risk of rebleeding. Okay, so in resuscitation, we always put in large bore IVs, preferably 2. Always use crystalloids first, drop the NG tube, and always anticipate the need for a blood transfusion. And the threshold should be based on the underlying condition, the hemodynamic status, and the markers for tissue hypoxia. Adults typically say hemoglobin above 7, and kids, when scouring the literature, I found people usually use a hemoglobin of 8. And we know that 5 mLs per kilo packed red cells raises the hemoglobin by 1. And if there's a coagulopathy, we need to correct it, but we also have to remember that as we keep giving packed red cells, we have to remember to replenish the plasma, okay? Some people use a 3 or 4 to 1 ratio of packed red cells to FFP transfusions, okay? So utility of an NG tube. It's most useful when the patient comes in with severe hematochezia and you're unsure whether this is an upper GI bleed or a lower GI bleed. Remember I said if it's a massive upper GI bleed, Blood is a cathartic and it comes out as hematochezia. So if you drop an NG tube and you lavage and you find bright red blood or coffee grounds, then it tells you that this hematochezia is really an upper GI bleed. It can also provide prognostic information. So if you see bright red blood coming out of this NG tube, it's predictive of a high-risk endoscopic lesion that's going to need some hemostatic intervention. If it's coffee grounds, it tells you that it's less severe and probably inactive bleeding because it's had time for the acid to act on the hemoglobin. Word of caution, okay? If you have a negative aspirate, it's not as helpful. As about 10 to 20% of patients with upper GI bleed can have a negative GI aspirate. Why? Either the bleeding stopped or the bleeding was beyond the pylorus and there was pylorospasm, so your NG tube didn't aspirate up the coffee grounds or the bright red blood. The NG tube can also be useful because it clears the field for the endoscopist because you've washed out the stomach, prevents aspiration in cirrhotics, it decreases the protein load, so prevents encephalopathy in cirrhotics. And if you leave that NG tube in till the patient gets to endoscopy, you can also check for ongoing or recurrent bleeding if you see bright red blood or coffee grounds coming out through that NG tube. This is a really old slide I found from the American Gastroenterology Society, but I want to draw your attention to two things. So you can have a clear NG aspirate and still have active bleeding in 10% of the patients. And if you see bright red blood coming out of the NG tube in adults, the incidence of death was 18%. So these are the two. The clear one is 10% active bleeding in spite of it being clear. And if you see bright red blood, there's a high mortality, morbidity. So take-home points, always look at airway breathing circulation. NG tube is always helpful, and don't hesitate to place one. I've had a couple of instances where the nurse was hesitant to place an NG tube, thinking, oh my gosh, I might cause more harm than good, but time to educate that it's always helpful to place an NG tube. It's very rare that placing an NG tube is going to cause more harm than give you more useful information. So regarding transfusion strategy, we have to remember that the initial hematocrit can be misleading. So when the child has had an acute GI bleed, they've lost blood, so they've lost plasma and red cells. So the initial hematocrit will tell you what the child's hematocrit was before the GI bleed. And after you've given IV fluid or crystalloid and there's been time for equilibrium to occur, that's when you'll see the real drop in the hematocrit. So in adults, like I said, most of the literature is in adults. So there was a study done in 2013 where they looked to see whether it was more beneficial to use a restrictive transfusion strategy or liberal transfusion strategy. So they had 921 patients with the severe acute upper GI bleed, and they used a restrictive transfusion strategy when the hemoglobin was less than 7, and they used a liberal transfusion strategy when the target hemoglobin was less than, transfused when the hemoglobin was less than 9 with a target of 9 to 11. And they found that the risk of rebleeding was higher with the liberal transfusion, but the primary outcome was similar at 45 days. So you can see here in their data that the risk of rebleeding was higher when you use a liberal transfusion strategy. So for coagulopathy, we have to assess the degree of coagulopathy by checking their coags. Vitamin K takes a long time to work, so it's really not that helpful to give vitamin K in an acute GI bleed. We give FFP because it's fast-acting and short-lived, and once again, don't forget, when you keep giving packed red cells, we have to remember to replenish FFP, okay? This comes up in adults mainly. They're on blood thinners and aspirin, and in adults, you have to weigh the risk and benefit of reversing this anticoagulation when they have a GI bleed. Fortunately, we don't have to deal with this much in pediatrics, but now with so much cardiothoracic surgery going on, we're going to have to face this too. I don't know how many of you have ever heard of this Sengstack and Blakemore tube. It's a tube that you can use in an emergent situation if you have a variceal GI bleed till your friendly gastroenterologist shows up to treat those varices. So basically, it's a tube and it has two balloons, one in the esophagus and the other one in the stomach, and there's a port down here to aspirate. So you place this tube, you inflate the balloon, and it actually puts pressure directly on the esophageal or gastric varices. So it's temporary control, and you have to attach it to a helmet. So first you have to find the tube in central, and then you have to make sure that they have the correct size helmet. I've been trying to do this for 3 years now where I am to see if they have a Sengstack and Blakemore tube, and I keep getting different answers. So you have to make sure that you have the helmet of the correct size to fit the kid, and you attach it. So this is just temporizing measure when you're stuck in the corner waiting for the gastroenterologist to treat those varices. There's a high-risk complication rate of necrosis and perforation of the esophagus. I've used it once 30 years ago and haven't had to use it again. I don't know, do you guys have it here?
Yeah, we do have it. Adult GI care.
Adult, yeah, but yeah, that's the story I hear. But pediatric size? Okay, so there was a study that looked at the outcomes based on the nature of bleeding. Once again, this is an adult study from last year. So they had 1,200 patients with bloody emesis and 700 patients with coffee grounds emesis. And the risk stratification was similar in both. But the patients that had the bloody emesis had a higher intervention rate of 19% compared to the patients who had coffee grounds that they needed endoscopic therapy, 14% compared to 19%. And the rebleeding rate was also higher in the patients who had bloody emesis compared to the patients that had coffee ground emesis. And if either of these groups, if they had concurrent melena, it worsened the outcomes in both the groups. So it's intuitive. If you have bright red blood compared to coffee grounds, you're going to have a higher incidence of mortality and intervention. Okay? So take-home point, early resuscitation reduces mortality. Place an NG tube in lavage, room temperature lavage, not ice cold anymore, and make sure that the patient is stabilized hemodynamically, crystalloids followed by packed red cells. So pre-endoscopy pharmacotherapy. PPIs. So PPIs decrease the need for endoscopic therapy. It also reduces the proportion of patients with high-risk endoscopic stigmata, downstages of lesions, so they don't need hemostatic therapy. It has not been shown to reduce the rebleeding, surgery, or mortality rates in adults who did require endoscopic therapy. We also use erythromycin IV given 30 minutes before endoscopy. It facilitates gastric emptying, so it clears up the field so the endoscopist can see the lesion that they're trying to treat. So for non-variceal upper GI bleeds, we give IV PPI, and the rationale is that it suppresses acid and it facilitates clot formation. We give the IV PPI till endoscopy, and then, based on the findings, decide if we're going to continue IV or change to PO. The dosing is either IV bolus twice daily, or sometimes we'll start a continuous infusion. I found a study that compared adult patients getting bolus IV PPI compared to the PPI drip. And they found that in the first 12 hours, it really didn't matter if you gave the PPI by an IV bolus or a continuous infusion. They both had the same amount of time, about 6 to 8 hours, in those first 12 hours where the pH was greater than 6. They also found that the time to get the pH above 6 when you give it IV bolus compared to a continuous infusion was not statistically significant. One was 2.5 hours with the infusion, and it was 5 hours with the IV bolus to get to that pH greater than 6. But they said that those numbers were not statistically significant. The recommendation is to give IV PPI, but you could be in a situation where you don't have access to IV PPI. Then the recommendation is to give an oral dose, but to give double the dose oral. And like I said, the IV erythromycin we give right before endoscopy to facilitate a better view of the field. So for variceal upper GI bleed, we will use octreotide, the synthetic analog of somatostatin, and it decreases the splanchnic blood flow, so it decreases the portal pressure. It also inhibits gastric secretion, and it may have some gastric cytoprotective effects. So it's indicated for variceal bleed, but we can sometimes use octreotide as a bridge in a patient with a non-variceal bleed to decrease the splanchnic blood flow, so to decrease the bleeding from the lesion. If endoscopy is unavailable, it's contraindicated or unsuccessful, and you're trying to bridge to your next relook. And for those patients, we use half the dose than we would use in a patient with variceal bleed. So after resuscitation, start PPI, and I wrote here somatostatin if you suspect a variceal bleed, but like I mentioned, you can use low-dose somatostatin in a non-variceal bleed, okay? So the adult literature talks a lot about risk stratification for patients to identify those patients at high risk for adverse outcomes and to help determine the disposition of the patient and to guide the timing of endoscopy. So adults use a Rockwell score. It's a validated predictor of mortality in adult patients with upper GI bleed. It's got two components. It's a clinical and an endoscopic. So after you've done endoscopy, then you've risk stratified them. And it uses comorbidities, whether they have shock, and on endoscopy, what the source of the bleeding was, and if there was any stigmata of active ongoing bleeding. So if you have a score greater than 8, you had a higher morbidity. And this just shows that as the score goes up, the mortality goes up, okay? Adults will also use a Blatchford score, and this score predicts the need for endoscopic therapy, and it's based on clinical presentation and lab data. So a score greater than 6, if you have a score greater than 6, there's a 50% chance that you're going to need some endoscopic intervention. So they use BUN, hemoglobin, blood pressure, and then pulse, and then if there's any comorbidities like hepatic disease or cardiac failure. So all hunky-dory for the adults. So what about kids? So in kids, there's a pediatric gastroenterologist in the UK, Dr. Thompson, who developed a Sheffield scoring system to predict need for endoscopy in children. And he used the history, clinical assessment, that's vital signs, lab data, and the need for blood transfusion or for any other blood product. The total score was 24, and if you had a score greater than 8, there was a high likelihood that you're going to need interventional endoscopic hemostasis, okay? An adult study looked at the outcomes based on the nature of bleeding. So what would happen if I already talked about this, sorry. So that's done with resuscitation, and then what about endoscopy? So there's plenty of things we can do during endoscopy. We can do banding or sclerotherapy of varices. You can do heater therapy. We can inject vasoconstrictors, sclerosants. We can use clips, and now there's a spray. So there's lots that can be done during endoscopy. And if all that fails, then we're at the mercy of the surgeon to go ahead and fix what needs to be fixed, and sometimes interventional radiology can help us out. So early endoscopy within 24 hours is recommended for most patients with an acute upper GI bleed, provided they're hemodynamically stable. If the bleeding can't be controlled, then you may have to go in and treat the lesion before they're hemodynamically stable. So the benefits of doing endoscopy, you make a diagnosis, you stop the bleeding, and you can provide risk stratification to see what's the chance of it rebleeding. And then in all peptic bleeds, you can determine the H.Pylori status in all the patients that have it. So this stigmata of bleeding based on endoscopy is actually an adult classification. So there's 4 classes. Either you see active bleeding, it's spurting or oozing, or you see a non-bleeding vessel when you scope, and these 3 need to be treated. If you find an adherent clot, it's controversial whether you do anything about it because the clot is sitting on top of the lesion. It all depends on the endoscopist, how aggressive they want to be, if they want to go and move the clot and treat the underlying lesion or not. And if you see just a flat pigmented spot or clean ulcer base, you don't need to do any endoscopic intervention. So this is the Delafoy lesion. You can see the blood spurting out, so that something needs to be done over there. Okay, this is you can see here a non-bleeding vessel, so we need to intervene here because this could rebleed. And then, like I said, for the adherent clot, you could do something about it, or you don't have to do anything about it. Either way is okay. I'm one of those that would, if I saw it sitting there and control the bleeding, I'd say not to do anything. And here's a flat pigmented spot, a clean ulcer base. You see there's no active bleeding, nothing going on in here, so you don't need to do any endoscopic treatment here. Okay? So what is the chance of rebleeding? So in the high strata here, if there's active bleeding, non-visible vessel, you can see the chance of rebleeding is high, anywhere from 40 to 90%. If there's an adherent clot, the chance of rebleeding is 0 to 30%. And if you have the flat pigmented spot or the clean base ulcer, there's a low chance of rebleeding, so you don't need to do any endoscopic therapy. And this just shows in a tabular form. If you have a clean ulcer base or arterial bleeding, what are the risks of the patient rebleeding? Okay. So endoscopic hemostatic therapy. So we can do, like I said, injections. We can do things mechanically, apply clips, ligation devices. There's a new spray that you can spray on the lesion, and you can do banding. We can do heat therapy with contact heat therapy with multipolar electrocautery probes or heater probe, or you can do non-contact heater therapy when you just spray on argon plasma and it produces heat. So for injection therapy, so we use epinephrine, 1 in 10,000, and we inject around the bleeding site in small aliquots. But monotherapy with injection therapy has a high risk of rebleeding. So with injection therapy, you have to do something else also. So it's always used in conjunction with other therapy. Often we'll do this injection therapy to kind of slow down the bleeding and then use a heater probe or gold probe to stop the bleeding completely. So mechanical therapy, we can apply clips down the scope. There's a forceps that has a clip attached at the end. You can actually go and clip the lesion. If there's a polyp that's bleeding and you want to take it off, if it's got a large stalk, you can actually apply a ligature around the base of it to stop the blood flow and then go ahead and snare the polyp off. And then we can do thermal therapy, like I said, contact heater probes. With we typically most commonly use a multipolar probe and non-contact with argon plasma coagulation. So the multipolar electrocoagulation therapy, so tissue is heated with electricity that passes between alternating areas of positive and negative electrodes at the tip of the probe. So you put the probe down and pass the current, and it desiccates the tissue and stops the bleeding. So it's actually called coactive coagulation. So you apply tamponade, you apply pressure to the vessel, and at the same time, the thermal energy coagulates the lesion and stops the bleeding. So the tissue resistance increases once it has been desiccated, preventing deeper coagulation so you don't perforate. Okay? So this is the gold probe. And then we can sometimes use argon plasma coagulation. It's a non-contact modality where you spray the argon plasma and you can stop the bleeding. It's typically used in areas with a larger surface area, more superficial area that's bleeding. If you had a stress gastritis and you saw some lesions bleeding, or a superficial AVM that was bleeding. There's a new spray on the market. I haven't had an opportunity to use it as yet. It's a nano powder with both cohesive and adhesive properties when it comes into contact with moisture, and it forms a stable mechanical barrier at the bleeding site. It comes in a little can You just press the trigger button and out comes the spray. So it enhances also clot formation and shortens the coagulation time. So the advantage is it's easy, and you don't have to be looking at the lesion end-on view when you're scoping. You can just spray in the general area, and it goes and it sticks to the area. You don't need any tissue contact, and you can use it as a temporizing measure if you don't have the facilities to do advanced endoscopic therapy. The reported success rate is 75 to 100% for initial hemostasis in non-variceal bleeding. It just got approved last year for use in the U.S. So post-endoscopy management in patients with non-variceal bleeding, if they have low-risk ulcers, they can be fed promptly and put on oral PPI therapy. But those with patients that need hemostatic therapy, we usually put them on a PPI for 72 hours. And it's been shown that if you do this, it reduces the rebleeding rate after you've done your endoscopic therapy. So any patient that gets scope, we're always looking, in upper GI bleeding, we're always looking for H. pylori, and if you find it, you treat it. Discharge the patients on PPI dictated by their underlying etiology, and mainly in adults, if they need NSAIDs or aspirin, then most typically we'll put them on double-dose PPI. I'm going to spend a little bit of time talking about endoscopic treatment for esophageal varices and portal hypertension. So why do you get portal hypertension? It could be intrahepatic, prehepatic, or posthepatic. So intrahepatic portal hypertension comes from mainly hepatocellular disease. It could be prehepatic if there's a portal vein occlusion or there's a portal venopathy or portal sclerosis. And it could be posthepatic if there's Budd-Chiari or IVC obstruction or congestive heart failure, and the pressure just backs up and you get portal hypertension. So the definition of portal hypertension is if you have your portal venous pressure greater than 12, and typically they'll present with splenomegaly or leukopenia due to the hypersplenism, and they can also present with esophageal varices or gastric varices and an upper GI bleed. The variceal bleed in portal hypertension often follows a cold when they've been coughing, or they have fever with increased cardiac output, or they've been on nonsteroidals for a short period of time prior to their GI bleed because it decreases the mucosal barrier. So 1/3 of the initial variceal bleeding episodes are fatal. Among survivors, 1/3 will bleed within 6 weeks. So whenever we do any endoscopic therapy, we usually take them back for relook to see what's going on, sometimes even sooner than 6 weeks. In children, the most common cause for portal hypertension is extrahepatic portal venous obstruction. If they've had like a UAC, UVC, and they got cavernous transformation of the portal vein. In adults, the most common cause for variceal bleeding is cirrhosis. So in adults, the predictors of large esophageal varices is the severity of the liver disease. If they have a higher child PEWS score, the severity of liver disease is higher. If their platelet count is less than 88,000, if they have a palpable spleen, or if their platelet count to spleen diameter ratio is less than 909. This is adult literature, okay? Sometimes we'll extrapolate and use in kids, but we always have to realize that it's adult literature. So kids with variceal bleeding typically will present as an acute GI bleed, and sometimes they'll present to the hematologist with splenomegaly and leukopenia and thrombocytopenia. It could be due to a hypocoagulable state or due to umbilical catheterization in the NICU. That goes back to getting that history when you have a patient that comes to the ER with an acute GI bleed. And the bleed is, like I said, typically precipitated. There's some precipitating events you may find, fever, cold, or NSAID exposure. I'm just going to run through quickly management of variceal bleed. It's variceal, so vasoconstrictor therapy, antibiotics, resuscitation, ICU care, endoscopy, alternative and rescue therapies, and beta blockage. So we already talked about using octreotide in patients that come with GI bleeding. Antibiotics is useful in patients who have underlying cirrhosis. It reduces the incidence of bacterial infection, significantly reduces early rebleeding. And we'll use ceftriaxone in patients with variceal bleeding. So resuscitation in patients, if known patient with variceal bleed, you don't want to overload their circulatory system because you'll increase the portal pressure and the pressure in the varices, and they'll bleed more. So you want to actually do a restrictive transfusion strategy in patients with a known variceal bleeding, okay? Endoscopy, this is the time when a known patient with a variceal bleed, you want to go in sooner rather than later to stop this bleeding because this variceal bleeding can be massive and fatal, okay? So what do we do for endoscopic therapy? It's pretty cool. You attach this cap at the end of the endoscope, and it's got rubber bands on it. And these rubber bands can be deployed from the outside. You have a little wheel. It's connected with a thread up to the wheel, and you can actually deploy these rubber bands. So you put this onto your scope, put it into the patient, and here you can see you suck up this varix into this little cup here, and once the varix is in, you deploy this rubber band, and there it is. It rubber bands that varix and causes it to have necrosis and falls off. So you can do multiple bands at one sitting in multiple varices to stop the bleeding. This is a picture of the varix that has been rubber banded. There's the rubber band, okay? And then eventually it'll necrose and fall off. You may have some post-sloughing bleeding after these things fall off. So unfortunately, it's always the kid, right? The banding equipment doesn't fit onto the, we call it the pediatric infant scope. So we cannot do banding if an infant, a small infant comes in with variceal bleeding. So then we have to go back to what we did decades ago. We use sclerosing agents to inject the varices. So you can use any one of these sclerosing agents, and you actually inject the varix, and it scleroses the varices. So once you've done your endoscopic therapy, we always put them on beta blockers because it reduces the risk for recurrent variceal hemorrhage. And the goal is to decrease the heart rate by 25% post-op. And you keep the patients on this beta blocker to prevent rebleeding. But in kids, we always have to be cognizant of the fact that when we use a beta blocker, their heart rate stays low, and the child's first response to acute blood loss is to increase their heart rate, to increase their cardiac output, but you have a patient on a beta blocker. So they may not be able to increase their heart rate in a situation where they've lost a lot of blood. So we always have to be cognizant about that. So I looked to see what is the mortality for GI bleeding in children. So there was a study that was done 2 years ago. It's a pediatric hospital information database. And this is all through ICD-9 codes. And they had 47 pediatric tertiary care centers, and they pulled patients that had acute upper GI bleeding or an indeterminate GI bleeding. And they had 19,000 patients, and the median age was 9 years. 50% had other comorbidities, 3 comorbidities. Either they were tech-dependent, had underlying GI disease, or neurological condition. And 33% of these patients presented with hematemesis, 40% with melanoma. 3% were in shock, and 18% needed packed red cell transfusion. The mortality was 0.37% in patients who had a principal diagnosis of GI bleeding. Interestingly, 48% of these patients died within the first 3 days of admission, and 20% received octreotide, meaning they had a suspicion for variceal bleeding, and 70% received PPI. They were less likely to have undergone endoscopy in those first 3 days, which I interpreted as the fact that they were so sick that they did not get their endoscopy done. Interestingly, there was a lower mortality that if they did have an endoscopy, it was protective, and the lower mortality if they came in with a primary diagnosis of GI bleeding. compared to patients who bled while they were in the hospital. And if they got PPI in the first or second day of admission, they had a lower mortality. So endoscopy and PPI was protective. That's what I took away from this article. So in summary, it's good to get your history and physical, do the resuscitation, risk stratification, place that NG tube, IV, large bore IV tubes, draw your blood work, correct your coagulopathy, pharmacotherapy with IV PPI. You can use octreotide if you suspect a GI bleed or if there's a massive non-variceal GI bleed. Maybe use a Sengstack and Blakemore tube, and then consult your friendly pediatric gastroenterologist and surgeon when you have a patient with an acute upper GI bleed, because you don't know which way this is going to go. So I was asked to put 2 questions. This one is straight out of prep. So my resident rotating with me this month found it for me. A 17-year-old adolescent boy is brought to the emergency department by EMS. His parents arrived shortly afterwards. They report that he was found unconscious in his bathroom surrounded by a large volume of bright red blood vomitus. They found a vodka bottle in his room. He is arousable but intoxicated. He continues to have intermittent hematemesis. He appears pale. His heart rate is 190, respiratory rate 32, and blood pressure 80/52. He has a soft abdomen that is tender to palpation in the epigastric area with hypoactive bowel sounds and no masses, and he has no rashes. His initial labs show a hemoglobin of 7 with a hematocrit of 25, and the rest of the labs are pending. Of the following, the most important next step is to A, obtain an abdominal film, perform a hemocultus stool, perform an upper endoscopy, start a proton pump inhibitor, type and cross-match for packed red blood cells. Any takers? It was E. The prep answer was E. Make sure you've prepared for that blood transfusion, so type and cross. I think this was prep, but I've modified it a little bit. A 14-year-old adolescent boy with a 5-day history of dizziness is brought to the ER for a syncopal episode. He has no heartburn, abdominal pain. He reports no alcohol or recreational drug abuse. He cannot recall the color of his stool and denies any vomiting. 14-year-old. He has a heart rate of 115, blood pressure 112/48. He is pale and fatigued. His abdomen is soft and non-tender, without masses or hepatosplenomegaly. A digital exam reveals burgundy hemocult positive liquid stool. Labs are drawn and IV fluids are started. The next step in the management of this child is to get a film, consult GI, place an NG tube, start an octreotide drip. Place an NG tube, because we don't know where he bled from. Is it upper or lower? Because when you did the rectal, you found bright red blood. Okay, I think that's it. I was going to do this, but we're running out of time. And my favorite slide. I'll be happy to take it. I love what I do, and I will be happy to take any questions.
So much for that lovely review. I remembered a lot more after you gave that great talk. I have one question though. In the medications that you use for bleeding in a patient, I didn't see any antifibrinolytics like Amicar or tranexamic acid. Are those ever used in this setting for GI bleeding to help stabilize that clot?
I've never used it. I didn't find anything in the literature using it.
Okay.
I don't know. I've never used it.
Any more questions?
You must be a hematologist.
I am. I've never used the I'm sorry.
With the Hemospray, I've not had that opportunity either. What's the risk of rebleeding? Do you know what that is?
They didn't say anything about the risk of rebleeding.
Like, is it like spray and then you're done, or?
It almost sounded like spray and you're done. I actually called the company. And they didn't have any data about, they didn't say anything.
Say like 75 to 100%.
We'll stop. Yeah, we'll stop. Have you used it here?
No, we have not, but we haven't.
Yeah. Adult GI has it. See, we always follow in the footsteps of adult GI. You know, I read an article when I was doing this. I hadn't looked at upper GI bleeding in a long time. It was really depressing to see that Dr. Thompson in England, he had published this paper where he polled all the consultants in the UK, and there were 19 centers that he polled, and there were 16 that replied. Of those 16 centers, 20% said that none of their GI consultants were equipped to do hemostatic therapy. That's a fourth, almost a fifth of them said that they were not trained to do it. And similarly, 20% said all their consultants were trained to do hemostatic therapy. And I think the reason why is that we don't see it as often in pediatrics as the adult population sees it. And it's, even if you do it, it's hard to keep your skills up if you don't keep doing it. I guess that's a good thing when kids don't have that much GI bleeding, but, you know. And then,
that's the importance of training in a center where you have that exposure.
But if you
and
don't,
that way, of course, and you may not do it, but once you do it once or twice, at least it's the start.
Yeah. And a lot of us pediatric gastroenterologists depend on our adults as moral support behind our shoulder. And that's just,
Any way that we cannot stop the bleeding, they're very helpful.
Yeah.
And placing all these patients MPO status, and then the progression of the diet. Is there a dysphagia style diet that you want to progress with? Or are they able to just?
I usually say follow the GERD diet: no caffeine, no spicy food, greasy food, mint, onion, chocolate, no foods that are going to stimulate acid production or irritate the mucosa that you've just treated.
We're all done. Thank you.